Great. Well, thank you everybody for joining. My name is Dan Winery. I'm head of strategic partnerships for Jukebox Health. Jukebox Health is a national provider of home modifications and environmental services. I'm joined by my friend and colleague, Ashish Shah. I'll let you introduce yourself.
Thanks, Dan, and good afternoon to all those that have joined us. Pleasure to be here today. I'm Ashish. I'm the CEO and co-founder of Dina. We offer a digital platform that helps Medicare Advantage plans and special need plans coordinate everything from traditional post-acute services all the way through to special supplemental benefits. So excited to be here today and spend the hour with all of you.
Great. Next slide. Just a quick snapshot of the agenda today. We're going to talk a little bit about what's going on in the industry, what we need to be paying attention to as both health plans and providers of services that are delivered to Medicare beneficiaries. We'll talk about program design, best practices for network and benefit management, how critical utilization tracking and analytics are. And at the end of the day, we'll close it out with a conversation around ROI and value and demonstrating the return for these supplemental benefits, which is so critical now with proposed rules coming down the pike. So as I said before, if you have questions, please submit them in the chat. We'll field them at the end, and anything that we don't get to cover, our contact information will be at the end of the presentation, and feel free to reach out to either or both of us to continue the discussion. Okay, so I'm sure all of you know these proposed rules that are coming down from CMS for 2025, contract year 2025, are really pushing health plans in the direction of demonstrating value and demonstrating return on the investments they're making in products and benefits and services. Historically, as we know, health plans have always used products and benefits to attract and retain their membership. That is not going to go away. This is a very competitive business. Medicare Advantage specifically, the market share is really difficult to capture. And in order to differentiate yourself from some of the larger health plans that are out there, it's really important to offer benefits that you know are going to be attractive to potential beneficiaries. Additionally, there's a lot of pressure around data collection and linking that information to programs. So we're moving from the past, right, a focus on growth and retention, to incorporating in your growth and retention plans, figuring out how to actually demonstrate value in improving and maintaining health outcomes for those supplemental benefits that you're offering. A focus on social determinants of health, a focus on health equity, and all of the data and services that go along with those benefits and those services. And from a utilization perspective and a marketing perspective, Ashish is going to talk a little bit more about that.
Yeah, and I think, Dan, it's a really exciting time in the industry. I think, as you touched on, there's no shortage of really exciting health plans that are out there. Of course, a competitive space, but love the absolute creativity to really identify new benefits that will allow seniors to age in place, to ultimately avoid, in some cases, institutional care. But really, we see this shift focused on scale. There's been wonderful pockets of innovation where, whether it's personal care services, or healthy meal delivery or nutrition programs, or home modification, which we'll talk about today. There have been really great pockets of innovation. I think wonderful success stories. If you really look at the proposed rules, it's really preparing the market for really a mass market and scale. And so, how do we really create greater repeatability and scale as it relates to utilization, the transparency, and what is the actual utilization rates, and then some proposed rules around just optimizing the member engagement and experience. So if you look at the low watermark threshold today, as it's proposed, within 6 months, health plans will be required to notify members of the benefits that they have available to them and what the actual utilization has been to date. And that's to avoid scenarios where someone didn't know about something wonderful that could ultimately help them really optimize their overall experience and outcomes. And then finally, there's been no shortage of wonderful academic research and literature that has proven the impact and value of many of these benefits. And so as we think about the next decade and the focus on addressing some of the challenges as it relates to health equity, as well as improving individuals and how they address challenges around social determinants of health, greater proposed focus on data sharing, Dan, as you mentioned, but to really help organizations both at the macro level of what's the impact of a benefit, which I know we're going to talk about here momentarily, but also at the individual level, longitudinally, what is the impact on quality, outcomes, and financial performance, quite frankly, when you're able to activate some of these benefits. So a really exciting moment in time, but I think there's some work for all of us to get prepared to go from that wonderful innovation to scale up mode, if you will.
And not a lot of time to get it done.
And now, not a lot of time to get it done. Correct. And so with that in mind, I think, I do want to talk about, just as we open up here, some of the challenges that we see in the market, Dan, as it relates to accessing some of these benefits. There's a number of ways that health plans have been experimenting or innovating to really improve that. No one is out there trying to not do a great job or not deliver a great member experience. Some offer concierge care coordination services where you can dial in and get a white glove experience. Others really trigger a process based off on an authorization request that may come in where internal care coordinators or navigators are trying to arrange the appropriate benefit based on the contracted vendor or provider of service. So there's a lot of different approaches. We're also seeing flex cards start to really be deployed at scale. Some of the things that make coordinating these benefits or optimizing the access and utilization is not only awareness, but also it's a fragmented ecosystem. We're talking about north of 30,000 home care providers alone if you just look at personal care services and hospice and palliative, which is being carved in. So it's a very large organization, large ecosystem, not many large enterprises that offer that scale. So there is no choice but to work with many different types of providers and vendors. Secondly, I think you're seeing increasing number of members who are frustrated with just trying to figure out how to navigate the map or the maze of how they get access to these benefits. One of the challenges that we've seen, especially since post-COVID, is a real challenge around just staffing of personal care services or other benefits. There's a huge labor shortage that's out there, and that has created challenges around just real-time availability and access, which can elongate the time that it takes for someone to ultimately get to a benefit. So there's just a lot of operational and logistical issues that are in the way. But I know, Dan, as we think about spotlighting home modification as an example of one of the challenges here, do you mind just sharing with our listeners today, first of all, what is home modification? Because I think there's a lot of different definitions. But then secondly, how does it typically work today with health plans that are trying to coordinate just that one benefit, not even thinking about meals or transportation or personal care?
Yeah, happy to. So just in terms of what is home modifications, what are home modifications, and what are the services around that? Allison, if you could go to the next slide, that would be helpful. So this maze that you see here is typically how a benefit like ours at Jukebox Health is administered. There are lots of moving parts and pieces. When we talk about home modifications, we're really focusing on falls risk, falls prevention, increasing independence, as Ashish mentioned. There's a lot of reliance on personal care hours, and that workforce, there's a shortage, there are challenges with quality. One way to address that need is to identify where homes can be modified for safety and independence. And that's one of the SLAs that we actually include in our contracts when we're working with health plans is, are we able to increase independence through the home modification? Because we know it is a challenge to get personal care services out to homes, right? So if we can help that person become more independent and focus on those activities of daily living through modifications, right? That's an opportunity to start to impact quality of life as well as cost of care and experience. So think of this in two ways, right? We have the health plan and operationalizing these benefits, not just home modifications. And then you have the members that are trying to access and utilize the benefits. Of course, there's an awareness issue, right? And I have asked my mother, she's a Medicare Advantage member. She had no idea that she had $250 given to her per quarter to use for OTC benefits. She had no clue, right? And I don't think she's alone in that. So making the members aware of these services and then helping them to navigate that system is really critical. And when you're a care coordinator or a social worker, or anybody that's working directly with the members, even member experience, having them navigate these services is a challenge, right? Clinicians did not go to school to specifically for home modifications. They didn't go to school to look at project budgets and construction costs and products and devices that might make sense for increasing independence and mobility and access, right? So this entire mess here, what happens is you have delays in service delivery. And when you're working specifically with members that are at high risk of suffering an injurious fall in their home, right? That time is of the essence. Any day that goes by, that person could fall again. We have gone into health plans where we've tried to clean out backlog of home modification support that people have been waiting months for services and months for support, and the health plans can't find a scalable solution to actually go out, assess the home from a clinical perspective with an occupational therapist, and then close the loop by actually providing the products and the support to install those products, right? We're actually finishing the job, right? So people there's time that goes by there and they're exposing themselves to more and more risk as these services become more and more difficult to access, to navigate, and to utilize.
Yeah. So Dan, if I understand it correctly, typically something is uncovered in a request for an assessment by the health plan. And then their job is ultimately to try to arrange all of it, who's going to go to the eval, who's going to actually, after the eval, figure out if there are modifications or devices or equipment that needs to be organized. I mean, it's an entire project that needs to be coordinated. So there's a lot of different moving parts. I guess, as I think about a little bit from our experience, what we're seeing from health plans is that there are real challenges to get a handle on. There's been such great innovations, but it's spread across a lot of different organizations. Creating a really clear view of are there complaints associated with the benefits to figure out what the issues may be so that they can actually address them in a timely way. In addition to that, also appeals and denials, right? If somebody needs home modifications been denied and kind of working through that process. And so this reminds me a little bit of if you just think about star ratings in particular and some of the things that have come out as it relates to just medication and medication management. If plans are offering benefits and don't really have a good handle on what the experience looks like around accessing that benefit, it's not a far reach to think that there could be potential impacts as it relates to just overall quality, of course, but how they're ultimately rated, which has a direct impact on revenue as well. It was neat to kind of hear your perspective on the kind of disjointed nature of it. Can you just spend a minute or two just talking us through what does it look like when it's working well with your health plan partners today? This is obviously a bit of a maze here right now, but
Yeah.
What does a best practice look like?
So, if you take a look at the ecosystem, right, there are lots of point solutions, especially if you're offering supplemental benefits that span across a number of social determinants of health or health equity needs. A best practice that we have seen and that we try to engage early on in the process with health plans is being a part of that strategy and having a seat at the table, right? It's incumbent upon all of us as service providers that are delivering the support in the home. It's incumbent upon all of us to understand what benefits are available to those members, right, outside of our own particular service. So from a point of entry, right? If we're the first people to come in contact at Jukebox with a Medicare Advantage member, right, and a beneficiary, it's incumbent upon us to understand what are those other needs that are available or that need to be addressed, right, through that evaluation so that we can be a part of that entire ecosystem. So when we talk about best practices for designing the benefit, we're not just saying, from a point solution, of course, this is available to your members, but also what other services fit into that realm for for the populations that you're serving. SSBCI and VBID are perfect examples of being able to really offer the most important benefits and services to populations of people. So when we work with a plan, we know that our benefit isn't for everybody, right? This isn't necessarily something that needs to span across your entire book of business and your entire population, right? We know which chronic conditions, which risk adjustable chronic conditions, all of those things, we know which ones lend themselves to a high risk of falls, right? Who is going to be at risk? So when we design the benefit, we want to focus on those people that we know we're going to have an impact with. That's also what CMS wants us to be able to demonstrate. Are the programs you're offering, are they going to show a return? Are you going to be saving on medical expense and cost, right? So when we identify the population, and we do that with our clients all the time, right? Who is at risk of falls? We can look at chronic conditions, of course, a history of falls, whether or not that person is on medication that would put them at risk of suffering a fall. So when we understand who that population is and where they live, right, then we can start to wrap the services around them. We know that people that are living with Alzheimer's disease or related dementias, for example, are 8 times more likely to suffer an injurious fall than someone not living with those chronic conditions. We also know that people living with Alzheimer's disease and related dementias have trouble accessing food and nutrition, right? That is a huge component of their overall health and wellness, as well as exercise and transportation. So you start to paint the picture when you identify the cohort of members, you start to paint the picture of all of the other benefits and services that member might need outside of the point solution. And then we start to get into what are we tracking, right? How are we measuring impact and value? It's not just growth and retention. It's, are we reducing ED visits? Are we reducing the number of falls? Right? And then we can customize the benefit from there. And then, of course, we start to engage, which is the most critical part, right? Once you define who's eligible for the benefit, the engagement strategy and the marketing piece is critical. And that's when we start to also engage community providers as well to get them on board. We hear so often from a modifications perspective that providers aren't able to actually recommend a solution to their patients when they've identified a fall risk. So they really don't get into detail and talk about it, right? So that hits on a star rating right there, right? They're not talking to their members about the risk of fall or what they can do because they don't have a solution to tie to it, right? So you start to see all of these components of the health plan: quality, risk, medical management, right? The growth and revenue piece, you start to see all of those come into play as soon as you start to really hone in and focus on the populations.
Yeah. Yeah, really neat. I guess from my perspective, Dan, some of the things that we're seeing is, best practice definitely identifying the needs of the individual, and you spotlighted home modification, but your comments really reminded me of some of the work that we're doing with plans in various parts of the country, whether it be a Medicare Advantage plan that's offering benefits part of SSBCI as you referenced, or it's a D-SNP plan that's serving both Medicare and Medicaid eligible members. It's typically a basket of benefits, and so I think we're moving from a market where we know that individual benefits can create value. But just to sort of add to your comments, it's not uncommon when someone is say it's a member part of a D-SNP, post-hospitalization for whatever reason, that may actually need support with a healthy meal program post-hospitalization, support with personal caregiver services. Really important to contrast that versus traditional home health. We're talking about somebody who may live alone at home and is vulnerable and needs help just sort of stabilizing with just their activities of daily living. And then also pairing that with perhaps transportation for follow-up appointments in a timely manner, as well as home modification, as you described. And so the challenges are unique when you need to align multiple benefit partners to work together. So some of these have experience working with health plans. Many of them are new to the game, if you will. They don't know necessarily even how to submit a claim. So I think trying to identify partners who are willing to work with other partners across the continuum that offer complementary services is something that we've certainly seen. But plans increasingly, the successful ones, starting to recognize that they need to move from sort of delegated point vendor solutions to setting up mission control or care traffic control for their organization, where they can activate multiple benefits, longitudinally coordinate and track how they're all working together, and then start to pull data back from them so they can understand what that longitudinal experience looks like. Of course, they're looking at total cost of care and making sure that they can hit the quality outcomes that they're shooting for. Again, not just for CMS stars, but for their own organizational differentiation and experience that they're trying to deliver. So just a few things that we see on our side, but not every benefit is the same. You know, what you described, Dan, with home modification could be something that is a single partner that helps a health plan coordinate all of the things that you described. Whereas on the personal care side, it's going to be very difficult to find one partner. And you just given the challenges with staffing and quality and turnaround. And so typically what we're seeing is that there's a broader network that needs to be coordinated. So each benefit's going to have a slightly different workflow and contracting rhythm and experience. But outcomes is really important. And so despite, irregardless of what the engagement model looks like for a transport or home mod, meal, or personal care, all of that data needs to come back and will need to come back to comply with this proposed rule that's been outlined. So perhaps we could take a couple of minutes to talk about some of the outcomes and what that looks like.
Yeah, and that was one of the things that really kind of drew us to Dina as a partner, right? There are things that that your platform is able to produce and report that on a global level, right? And as on a kind of total benefit management perspective, right? We're a piece of the puzzle, right? But at the end of the day, you need to have confidence in the partners that you're bringing to the table from a network perspective, that we're able to actually provide you with the information to feed your platform as well, right? So we'll take a look here, kind of, you know, from a home modifications piece, right? It's not just focusing on that return on investment from a clinical outcomes perspective. We want to also be your partner in benefit design, right? So we're tracking utilization at the minute details, right? Are we filling more orders for grab bars? Are we doing more tub cuts? Are we installing more ramps? Where are those rooms that have the greatest risk of a home hazard, so that we can help inform our clients, that health plan, on how to actually design benefits in the future. No home, you know, no two homes look the same, right? No two members look the same in terms of their needs and what their risks might be. So for us, being able to report utilization on a programmatic level is really critical to demonstrating the value, not just from a clinical outcomes perspective, but as a good business partner, right? And Ashish, you mentioned before being able to collaborate and coordinate with other partners, right? The real, you know, the real benefit of being able to have a partner like Dina is you're also able to connect other vendors like Jukebox to those other services, so that we can then cross refer, we can have similar workflows, right, in terms of identifying needs and then sharing information across the entire ecosystem, which is a huge value to the plan and to the member.
Yeah, and Dan, I think also one of the things that we see is we just haven't been able to find a vendor or a partner that can do it all. You know, there's always a reason where perhaps there's a delay or it's out of a coverage area. And so one of the predictors of success, in addition to just the ultimate outcome, you know, is the member satisfied, and are they avoiding, you know, costly care, and are they staying on their care pathway, is responsiveness. Are they meeting the SLAs of the organization? So many of the outcome metrics that we are unlocking for our partners have to do with, do they have the right coverage? Do they have the right staffing level? Are they responsive? To what extent are they accepting but not able to ultimately activate the delivery of that benefit? We see a lot of referral no-show type of scenarios as an example. Where is something getting caught in authorization? This macro level reporting, I think, is really important to help the health plan consistently deliver the benefit, regardless of which partner is in place. So a lot of the things that you talked about are really great. I think the aim for the plans that we're talking to is how do we take the type of capabilities that Jukebox is really delivering and make it almost standard and easy to manage and scale within the health plan operations, within that mission control setup that we talked about. I can't tell you the number of times that we see someone that's been tagged as potentially a tier 1 provider or a partner and move down because of their availability and turnaround time, because there's some visibility. And then also those who are perhaps tier 3 or tier 4 and actually move up the ladder, just given their responsiveness. So I think transparency in all this data is really good for the members ultimately, but I think it's good for all the partners across the continuum as well.
And those are things that can be put into the contracts, right? I mean, we welcome that, and hopefully when people are selecting their vendor partners, they're having these open discussions around what are those turnaround times, what are those SLAs for delivering the service in the home. The last thing you want is to have a negative member experience because of a lack of coverage, right? Or the no-shows. So being able to put those into contracts and finding partners that are willing to really kind of put the money where their mouths are, right? And speak to that test, then you're gonna see improvement across the board.
Yeah. I think this is a new type, as we've talked about, many of these are new benefits. Unlike other types of networks, provider networks that have had, that have been built in, by health plans, it's not uncommon that there is provider abrasion that needs to be addressed. And so the plan needs to make it easy to work with the providers and vice versa, and network adequacy. And so if you're going to offer a benefit, you need to make sure that you've got the appropriate coverage capabilities. So in many ways, things that have been successful in, again, medications, specialist networks, primary care, ambulatory and other surgical center needs, that same sort of thinking around benefit management design is coming to this part of healthcare, increasingly non-medical or pseudo-medical services. So there's, we don't need to reinvent the wheel per se. There's a lot of things that people have learned, but it is new in terms of the types of providers that they're working with. Maybe we can, we talked a little bit about the individual value that's created for a member, and we talked about that macro level reporting. I think you guys have done some really great work, Dan, and just in our private conversations around, how are you communicating ROI? I think this is another key area for CMS. So if a benefit's being offered, and there has been some academic literature that supports that this is good, how are you ultimately helping your plan partners really understand the value of a benefit, using home modifications as an example, but every benefit's going to need something like this?
Yeah, of course. And I've been fielding requests from either current plan partners or prospective plan partners to provide them with research, right? With data that demonstrates that the interventions that we are offering via the benefit have an impact on health outcomes and have a return on investment. There isn't a ton of research that's out there for a lot of these supplemental benefits. Luckily for us, when it comes to falls, right there, it is a very highly researched, a lot of information out there about the return that a home modification can have on a fall reduction and cost reduction. So we were a bit ahead of the game, but we took it a step further. As soon as these proposed rules came out, we made the investment in creating an actuarial model, right? So that when a health plan actually needs to submit to CMS what they're anticipating that return to be in terms of cost savings, right? We are very prepared to run their data through the model. We are looking at cost, quality, experience, utilization, and growth and retention, of course, right? All of those things combined. At the end of the day, we want to be held to, and your other providers should be held to things like this as well. for every dollar we're spending, how many are we saving? So if we're looking at falls specifically, we know that falls are the #1 cause of injury and death in people over the age of 65. We know that 4 out of 5 home hazard or 4 out of 5 falls happen because of a home hazard that can be avoided and removed. So if we're looking at the eligible population, and I can't stress this enough, it's so important to get the right population identified first so that you know you're optimizing your dollars, right? You're not spreading it thin across the entire population. I said that earlier, right? You're very focused, very targeted. You've agreed on the eligibility criteria because you know that's where you're going to get the most return on that investment. So identifying those people that are at highest risk of falls, whether it's chronic conditions or past utilization or fear of falling reported via annual wellness visits or just conversations with care managers, right? We can then start to work backwards and say, all right, because of that occupational therapist going out and doing the home evaluation, prioritizing the recommendations for modifications in the home with the family, right? We are anticipating that we can really reduce falls significantly. Of course, we have to pick the right population. The average cost of a fall today is thousands and thousands of dollars, right? It depends on the area and of course the population, but on average, we're very confident that we're able to show at least a 3x ROI for a minor home modification project, right? We're not talking about ripping and replacing bathrooms here. We're talking
Yeah.
about thoughtful, clinically driven decisions about products and devices that are going to really make a difference.
Yeah. And Dan, just kind of looking at VBID for as an example, every benefit that ultimately is proposed kind of goes through a journey like this, right? They need to kind of go through the process of sort of proving its value before it ultimately graduates to something that can be offered at scale. Is that right?
That's correct, right? And these are, from our perspective at Jukebox, I mean, these are returns that you're going to see in the first year, right? So
Mhm.
not only are we designing programs that are going to have immediate impact, but the modifications are staying there, right? So we could be reducing falls year over year over year, right? And that's really important. And I think as we move to the edict of 2030, where value contracts are required, right? This
Mhm.
is really setting everybody up for success because you know that these programs and the work that you've done on the front end is really showing a return. So yeah, I think that's an excellent point, whether it's SSBCI or VBID. You have to be able to identify, who needs it in order to really show that return.
Yeah. And just reflecting on some of the prior conversations across the industry, you know, senior fitness programs have had to go through a journey like that, vision and dental, which, I know there's a push for that to become standard benefits versus supplemental benefits. But I think, as I think about plans, having a, single pane of glass, if you will, to sort of monitor all of your benefits and what is that broader ROI impact, um, is going to really require a lot of data to be shared in order to support it. It's the right thing to do. It's just going to take a little bit of work to wire up all of the organizations.
Yeah, I think, with Dina being able to, bring all of that information and that data together is going to be so helpful. Health plans have always struggled with attributing savings to a specific intervention. But if we're looking at it at the member level and all of the interventions combined, right, then, we can really start to take a look and see through the information that Dina is sharing, right, across all of the benefit providers, where the impact is being made and where the value is being realized.
Yeah. We sort of see it as two acts. Act one is you need to organize your network of benefit partners and you need to be able to ultimately unlock faster and cleaner access. But the second part is data needs to flow back. Not only for fraud, waste, and abuse purposes, which is, these are things that have been widely discussed across the industry, but to do the outcome and impact reporting and analytics that you just mentioned. Well, I know that we're nearing the end of some of the content that we have prepared here, and we're going to get to some Q&A. So just as we think about wrapping up some of the prepared material here, Dan, I think we've talked about this a little bit in the past. The train has left the station. There's been just incredible innovation to date. Yes, in home modification, but in other benefit areas. And if you look at a lot of the proposed rule, uh, and what has the potential of being final here in the very near term, is to really prepare the mass market to scale up these wonderful benefits. The innovation has really proven that there's a lot of potential here, but these are going to be non-negotiable. If you offer a benefit, what's the actual utilization rate? How are you taking the appropriate steps if you're a health plan to inform your membership of the benefits that are personalized and available to them, and what the usage has been to date? Yes, within 6 months, which is the way it's written today, but probably more incrementally to really drive heightened engagement. And then really linking back, as we just discussed, around the impact at a macro level around a benefit, but at the individual level. And I think the proposed rule, we'll see if it ultimately goes final or not, but talks about member level bibliographies and being able to actually, if you activated home modification and nutrition and transport as examples, what was the actual longitudinal impact to the member? That's going to require a lot of data to be exchanged. It's not being shared today, but an exciting future nonetheless. I think our job as supporting cast in the industry is to really make sure that technology and data can be helpful and useful, but it has to be easy as well. So I think clearly the entire segment is moving in this direction. As we think about just sort of the final wrap up, what we're seeing successful health plans think about is if you're building a network and you're designing these great benefits, it could be a single one or a multitude. We're seeing plans really prioritize responsive and collaborative partners. Responsive meaning, can they turn around requests quickly? Can they communicate in real time or near real time? Can they share data back? And some of this data is not necessarily always formal. It could be a proprietary assessment that a home modification company or a personal care or DME company is filling out, but it's information that the plan typically doesn't have. And so that commitment to data sharing, I think, is what's required to ultimately deliver on some of these proposed rules. Staffing, don't sign up for more than you can actually do. I mean, this is a very large market. There's a lot of people to serve, but being able to, over promising and under delivering on a benefit only hurts health plan partners. And I think health plans are very sensitive to that as well. Look for the champions out there. ROI, I think, is going to be non-negotiable. I think being able to look at the individual benefit level, but down to the individual member level is going to be table stakes moving forward. And then all of this needs to be correlated back to the member experience. Initially, it will be just in terms of overall member experience as captured and measured through stars, but would not be surprised if you continue to see the STAR program evolve in a direction where satisfaction as it relates to supplemental benefits is something that's asked and ultimately measured. So I think plans are cognizant that the rules are changing here, and I think they're really going to lean on their partners to help them be successful. These are just some of the things that we've heard. Dan, I want to give you an opportunity to have any final words that you have, but these are some of the things that we've seen from our perspective.
No, you're hitting on all the key points. And from our point of view, right, knowing that we are a piece and a part in that ecosystem, partnering with other service providers to deliver the care and coordinate the care, partners like Dina, partners like folks in the nutrition and the transportation space, pest control, right, all of these other supplemental benefits, we are very open and willing to share best practices, to coordinate workflows, and I think that's really just in the best interest of the shared health plan client, right? So I think that's just really important. Your willingness to collaborate and work with others is going to really drive decisions too.
Yeah. Hey, Dan, your comments remind me of just a rising tide lifts all boats. And I think this is one of these scenarios where it's not a winner take all, if you will. It's collaboration, I think, is going to be key across the entire space. Well, I just want to take a moment to say thank you on behalf of Dan and Jukebox and myself and Dina. There's a number of ways to reach us. Of course, here are our email, and you can find us on LinkedIn individually. But just a quick ask for all of the listeners today: if you could follow us on LinkedIn as well. Content like this is something that both organizations are quite committed to. So as it relates to just emerging regulation, how it's evolving, thought leadership, what are our customers or the bright spots that we're seeing in the industry. You can find both organizations on LinkedIn, and that's the preferred way that you can track us. But please don't hesitate to reach out. And then I know that there's some questions that are coming in, and so I think Allison's going to guide us through a little bit of Q&A here, given that we've got about 10 to 15 minutes left. So thanks again for taking the time to listen to the prepared remarks, but excited to answer any questions here.
Yeah, so it looks like a few questions have come in. I don't know if you're able to see these on your end.
I can. Ashish, we have one question here. It says, when does the final rule go into place, and when does it need to be implemented?
Yeah, really great question. And some of these things can be a little bit fuzzy, but it looks like just following the general pattern for previous proposed rules, likely to go final in the mid-spring timeline around April, with an implementation date of 1/1, which means that you need to start working backwards if you're a health plan to really have a handle on the proposed rule. Think about what your implementation approach is going to be sooner rather than later. And ideally, regulation is sort of, again, low water mark. If you can start to put the infrastructure in place in ahead of time, where checking the regulatory compliance box is something that's fairly straightforward. That's sort of what we've seen other organizations do. So April going final, and then implementation 1/1/2025.
And if I've learned anything about either working at a health plan or as a service vendor into a health plan, the contracting piece is always lengthy, right? So these decisions are going to be made quickly, if not within the next couple of months, and that initiates the long contracting process across the company. So that's something to always consider, as well as you're working backwards in your timeline, right? How long is it going to take to move through the legal process? Which brings me to this other question here. What's the appropriate length of a contract for a pilot with a new partner? So I get this question a lot, actually, and I get the question from the plans. For an intervention that you're trying to measure return on investment, it's impossible really to demonstrate any kind of longitudinal or multi-year impact with these single year agreements, right? These are things that need to be extended over the period of time and ultimately positioned for value. So typically we're looking at a 2 to 3 year engagement, where we are measuring outcomes. We have a lot of milestones along the way, ultimately positioning the relationship and the agreement to be positioned for value, right? And risk and performance. So, you have to have that first year to collect as much data as you can, work out the kinks, right? See where you're making that impact, and then growing from there and extending the contract length along the way. So that's from my perspective.
Yeah, and Dan, just to add to that a little bit, sometimes when you see perhaps a more utilized benefit, it's not uncommon to, in addition to having your current contract with your providers or vendors, the need for capacity that leads you to a one-time only case or contract that needs to be created with the provider, or same-day case. And so we've seen perhaps your preferred provider partners having a longer agreement, like Dan, like you described, but there's a healthy amount of just-in-time contracting that takes place as well.
And I've always been very cognizant of members don't like benefits to disappear, right? They like consistency, right? Which is great and necessary. And especially if you're measuring impact, it needs to happen over the course of the years. But when you're talking about experience and the marketing and the growth piece, if you're stripping away benefits and replacing them with other ones, it becomes more confusing, and you're jeopardizing experience and also loyalty, that retention piece. So I think that was our last question. Yeah, looks like it. Should we call it, Ashish?
Yeah, I think just as a refresher again, you encourage everyone who's listening or who will listen later to take note of the contact information. Would love to continue the dialogue. Again, you can find us on LinkedIn, and we're quite excited to see this proposed rule from CMS. It's going to create some work for everyone involved, but I think it's overwhelmingly a wonderful signal that the innovation that's been taking place in the industry to, again, address many of the challenges as it relates to health equity, but also addressing some of that with social determinants of health. A real clear recognition that we need to collectively work on how to scale that up so that it becomes something that's available for all members in all plans. So really excited to continue the conversation. Appreciate everyone for joining in today.
Great. Thanks so much. Thanks, everybody.
Take care.